Right. Good afternoon, everyone. Dear colleagues, dear panel members, thank you for having me. It's a great pleasure and honor to be here in Sofia to talk about a very exciting topic, which is the MMA embolization, something new in the field, and therefore also, sorry, let me just get rid of this. I lost my slides here, okay. Just a moment. All gone. Okay, meanwhile, how many of you are doing chronic subdural hematoma treatment by embolization? Any of the, Ramon, of course? Yeah. Any of you? We set out a survey over Europe with the ENS, and we found that only 1 out of 8 centers overall has implemented MMA embolization in Europe, which is rather a poor rate or number. I see that this is... Yeah, I have my charger with me, but I don't know why the screen is black here. Sorry for that. Of course, this happens when everybody is hungry and ready for coffee. Okay, well, I'll just continue. My disclosures, I love Sofia. And I get invited by Nouri, he's a dear friend of mine, but I should disclose that every time I come here, he puts me up for work in his busy practice. So when something new comes in, please do bring the charger if possible. So when something new comes upon our horizon, you know, I think it's important to ask basic questions. Who, what, where, why, all these questions. I can't really cover all of these questions, but what I will do is try to break it down of why I think, because I'm a hybrid neurosurgeon, why this field is so important in improving patient outcome and treatment outcome in chronic subdural. Thanks a zillion. Thank you. So first reason is we are really performing badly as neurosurgeons. I should really tell you this, because 1 out of 5 patients we treat gets a recurrence. And from that 20%, again, 15 to 20% gets a second recurrence, which means that the morbidity and eventually also mortality should not be underestimated. This is a paper we put out recently. And then the actual incidence is also projected to increase. It's already now the most common performed neurosurgical cranial procedure. And last but not least is that from these novel trials, these high-impact trials, we have already learned that we have broadened the indication of treatment. You know, so if a patient would come to us as neurosurgeons with slight, let's say, disturbances, headache or some difficulties in concentration and memory, we would not treat them. But now from these trials, as I will show, an embolization could be the perfect fit. And so you have expanded the indication for treatment. So what do we have learned? The what question. This is a recent meta-analysis from the 7 RCTs that have been performed. It's, of course, not only embolized stem and magic MT. We have learned that the treatment success rate will increase if you combine treatments, as simple as that. However, the number needed to treat is still very high. We come up to a number needed to treat of 14. You should treat 14 patients to overcome 1 recurrence, let's say. But also, if you, again, look back at the why reason, why are we treating, that only 2 of these trials have looked at patients for a standalone treatment. And if you do a standalone versus conservative, MMA will win. If you do a MMA versus surgery for these polysymptomatic patients, surgery will win. But here comes the point that we really need to question. And I believe that so far the trials have had really a primary endpoint mismatch, because you're doing the treatment to overcome recurrence, to decrease the recurrence rate. However, they measure the clinical outcome by modified ranking scale, okay? And then also we know that it takes up to 3 to 6 months before you get the decrease of the hematoma volume after a embolization. So what this means to me is that, okay, if you want to check for recurrence and reoperation, as you can see from the meta-analysis, you get significant results. But if you look at the MRS, which is actually most important to patients, the treatment fails so far. And again, the expectation to decrease the ICP by embolization alone is a myth, of course. However, the goal to obstruct leaky vessels, that's of course what should be measured. Continuing on the trials that appeared, the EmProtect, you all know about it, also recently appeared, but had no significant reduction in the recurrence rate. So only a 6% absolute difference between embolization versus embolization with or without Burhole craniotomy, and only 6% absolute difference rate. One more promising trial, in my opinion, is the OTAMAX, which is currently being almost concluded in France by Costala and his partners. And what I like about this trial is that they will include real-life scenarios. So also the higher grade Mark Walder patients with a big hematoma, with comatose presentation at the emergency department. And what they do, they would then randomize patients, of course, 1-to-1 in an open label strategy, and then they would embolize within 72 hours. So that's quite fast, but is it fast enough? And let me ask you this. We now know that the term chronic subdural hematoma is really off. It's not the correct term. It appears to be an inflammation of the dura, so not even in the subdural space, right? And even more, if we treat meningiomas, we do embolization up front, right? We want to see the effects of embolization, then you will facilitate surgery or you will alleviate the necessity of surgery. What about AVMs? Who would do an embolization after resection? I mean, this is, of course, a silly question, but consider that if you want to reach the maximum effect of your embolization, why wouldn't we treat patients up front? And again, Embolize and STEM were the only ones that would do upfront embolization. I brought for you 2 cases of myself to show, lessons learned, because eventually, even though there is evidence now that we can do this, how to deal with it in practice is still not very clear, especially not in Europe, because again, from our questionnaire, the implementation of MMA has not matured in Europe. So this is a patient with a treatment dilemma. He had a chronic subdural, but also a 4-centimeter clot in his heart. He was treated with Burhole craniotomy, and within 6 weeks, he had this large recurrence on the left side. And he was really affected by it. So he had slight disturbances in speech. He had a grade 3 hemiparesis on that side. And we decided to go for a adjuvant MMA embolization. This was done at week 8. And I decided to treat him immediately with therapeutic anticoagulants, because I said the risk for you in your heart after MMA embolization is higher than the odds of having a second recurrence. And what we see is that when you do imaging up front after 3 weeks, you can already see an entirely disappearance of this collection. So why am I showing this case? Because in literature, we mentioned that you have to wait 3 months, 6 months before you can expect this hematoma to resorb. But in some cases, the standalone treatment as a second tier could help you as well. The second case, again, is one as a first-tier treatment. And why do I love this? Because it's very beneficial to the patient. It's an outpatient clinic treatment, no hospitalization, no need for cessation of anticoagulants or anti-aggregants. And this patient was indeed polysymptomatic. He had concentration disturbances, headaches, but was still walking around. So we did the treatment, and 2 months post-embo, bilaterally treated MMA embolization, the pathology was disappeared entirely. And why my preference for liquid embolics? I think you really get better control, because the case I just showed, there was a connection to an orbital branch. It was not a direct connection to the ophthalmic artery, but still, I think that you should not go into this vessel. And with these liquid embolics, you can do a controlled backflow and just stop at the level of this bifurcation. Okay, let's go back to real life, where we have most of the patients that come into the hospital are Mark Walder 3 and 4. If you have a headache, your GP may not refer you. If you have a hemiparesis, you will go to the emergency department, right? So it's exactly these patients that were excluded from STEM, Embolize, and Magic MT. And I think that in the future, if you want to set up a protocol in your hospital, you should really consider having recurrence cases and those that have indication for MMA embolization on for another reason. For instance, if they're polysymptomatic, if there is a strict indication for anticoagulants, like the first case I showed you, and if the patient is really unfit for surgery, for anesthesia, meaning, or for a hospitalization. Last but not least, we are also participating in a trial called TORCH, and there is also this Tabasco trial ongoing of, this is really the competitor. You know, I think that what we learned from these trials, these are patients that are treated conservatively or randomized in placebo or tranexamic acid upfront for 1 month, okay, 4 weeks of treatment. And what we see now, as I can disclose, this is from Amsterdam, that 1/3 of all inclusions do not need surgery. So we can prevent already in 1/3 of these patients to go for borough craniostomy. What are the future prospects? As mentioned, Automax, I put much faith in this study, since I think that the inclusions of these higher Mark Wald grades is very relevant to us. And also on the first tier, there are 2 studies on the way, SWEMA, the Swiss embolization trial, and the CHESS from Canada. These probably will also elucidate the role of first tier treatment. And also the hybrid OR, okay? This is, I truly advocate for, if you have a patient that comes in that has signs or medication that makes him or her prone for a recurrent hematoma, consider of doing it simultaneously, embolization and borough craniostomy in one go. I think that was what I wanted to mention. Thank you very much. I'm happy to take your questions.
Thank you very much. Are there any questions to the presenter? Thank you, very interesting. I really want to invite you at some of our morning meetings with our neurosurgeon colleagues, which continuously claims they have 0 or less than 1% recurrence rate. Okay. And sometimes they argue with me with the fact, what do you call recurrence?
What do you, sorry?
What do you call recurrence? Because they want to flip that argument all the time. Above 1 centimeter, if it's the size, the patient is asymptomatic, so we don't touch it. If it's less than 1 centimeter, it will never regrow again. But they like do 1 or 2 follow-ups, and that's enough for them to say our surgery does the job.
Yeah, sure. But I also know that it's exactly those colleagues that do treat 1 centimeter hematomas without midline shift and so on, right?
I argue with them when they're presented for surgery, it's a, we should do it. Yeah. When do you, like, of the follow-up and see something the same or even...
I didn't mention it, but there are also 2 nice meta-analyses on the cessation of antithrombotic antiaggregants and a almost twice incidence of stroke within 3 months. So, you know, if you have atrial fibrillation without treatment, you have a 5% risk of having a stroke, right? If you do cessation for these cases. And as you said, 4 weeks is not enough. You should probably hold back the anti-thrombotic or anticoagulants for more than 6 weeks if you want to achieve results. So your odds of inflicting stroke becomes very relevant, right? So if you have a fragile patient, let's not forget, these are the elderly, fragile, multi-comorbid patients, right? So then if a 30-minute procedure, you can embolize both sides and just continue with the treatment, I think that saves you not only your patient, but also hospitalization costs. It's a win for society.
So the other their arguments is they do it with local anesthesia, small borehole, less percentage of complication rate like inflammatory other complications. I cannot agree with that. So but they claims it's even faster than the embolization. Maybe our neurosurgeons are very good. I don't want to say something else, but how you're dealing or you're maybe
so
not
again,
dealing with such
you should then step back there to what is this pathology exactly? For a long time, we thought that it was bridging veins that would rupture and cause, it's inflammation of one layer of the dura, the most inner layer. So you're only treating the mass effect with surgery, right? Then you would argue, okay, we have learned that if you leave a drain, right, subdural drain,
and if you do, suggest that.
Yeah, and if you rinse the hematoma, you probably will decrease the inflammation. This is right. I believe it's true. But that would need a 2 or 3 day hospitalization, right? A lot of patients ending up with pneumonia, delirium, recurrence, air trapped inside their skull, Is he a neurosurgeon? You always
No, we are both radiologists which are fighting with such discussion that they never observe such things in our department. So if I have to be honest, at the beginning in 2018, 2019, when they suggest embolization of the MMA for subdural chronic hematoma, I said, what we are going to change? I didn't believe in that. I really didn't believe because the mechanism was something, what you stop. Yeah. But then I saw it disappears. I still don't know how, but the MMA works.
Yes, the MMA works because, this is a disease of microvasculature. You do not see it. You have in very severe cases, you see these cotton wool blushes like with meningiomas, right? But this is a microvasculature problem. And it's also inflammatory. So if you don't stop it, it will only, recur or it's a type 3, in fact, type 3 inflammation. So again, if you treat it, you are basically taking down a gradient. In the past, they said it was osmosis, but it's not osmosis. It's really a pressure gradient. And this is also why I believe that if you do the treatment, you stop the gradient, you get clinical improvement before you get radiological improvement. Okay, because the brain can push back.
If I may take a joke, you're never going to be recognized like a neurosurgeon here in Bulgaria with such claims. So thank you.
Thank you very much. Yeah, so that's a good question. Actually, it was a Dutch trial by Ruben Dammers, one of our friends. They really investigated and did an RCT on corticosteroids. The only effect you get is high blood sugar levels and no significant improvement for your patient. So more patients with delirium and more elevated blood sugar, no effect on treatment outcome.
I'm asking after the treatment with the embolization of MMA,
yeah.
with liquid, do you give corticosteroids? Because in AVMs, for example, we are giving both dose.
Yeah. Well, I think, again, so if you do it targeted, if you would inject fluids through the MMA, I think that could, like local installation of corticosteroids might be an option because you're there. But giving it systematically, I think, is a mistake, given the current evidence. Okay?
Dara, based on your experience, do you prefer treating this patient under general anesthesia or local anesthesia?
General anesthesia, yeah. I know that the next speaker will talk about local installation of lidocaine. It's possible. I think that if you really want to, because sometimes when you do injections and you do in any embolization case, the morphology may change. You will open up collaterals. Sometimes I embolize and I see there is a collateral coming from the skull base, right? And this you might miss if you're on the local and there are movements. I want to be as precise as possible. Thank you.
And Dara was the last question. Do you do the embolization bilaterally, systematically?
Yes, I do now. So I think it's a small increment of the treatment, maybe 5 to 10 minutes extra to catheterize the other side. And what we really saw is that if you do the AP view, you get vessels crossing from left to right. And again, you want to be as successful as possible. You know, there are reports on that only one branch of the MMA can give good results. I'm a bit skeptical about that. I think that if the collection or the inflammation can recruit over the falx and over the contralateral side, you get recurrences.
Do you recommend distal penetration, or it doesn't matter if you have completely proximal?
So yes, again, a good question. I think you should go as distal as possible.
Penetrated.
Yes. Yes.
I have a small question.
Yes, please.
You finished your talk with the future perspectives slide, right? So I have a maybe theoretical question. Do you think there is like a room for biological treatment of the...
Excellent question, yeah. I think that, you know, we are talking already currently about an adjunct. So you're asking, can we do an adjunct on the adjunct, right? So if you're, sorry? But you mean systematically or to inject biologicals?
Like anti-BGF inhibitors directly into the dura.
Yeah. Okay.
Because with inhibitor we provided the skin, right? Only giving prevalence to the human body to take over the chromatoma and inflammation. That's
Yeah.
the point, right?
Yeah.
If we give those BGF inhibitors, do you think we can like allow the dura to still be perfused while reducing the...
No, of course, the honest answer is I don't know. It might work, but the question is, do we need it? You know, anti-VEGF is not such a benign treatment at all. You know, if it ends up somewhere you don't want, it may have adverse events, especially in these elderly patients. Second is, it may be temporary, whereas we know this is a chronic situation, right? So if you get washout of your treatment, if you do VEGF, yeah, okay, then like in, for instance, glioblastoma patients or tumor cases, they get it administered once in a while, right? So a one-time injection or a one-time treatment, I don't think that is really sensible. And I also would doubt if currently with treatments we do, that this adjunct would be significant in getting better results. What I do think is that we should search in ways we do in Utrecht. We know that Savastano is also on it, Simone is well aware, to treat the mass effect. You know, I'm developing a laser catheter that can puncture the dura and then also remove the hematoma. But maybe I can talk about that next year. Thank you.
Thank you. Let's have 20 minutes of coffee break and be here at 4:30 sharp. Thanks.